My name is Len Finocchio. I'm a Senior Program Officer at the California Healthcare Foundation, and welcome. We are going to talk about the financial feasibility of a basic health program option for the state of California. I'm with the Health Reform and Public Programs Initiative at the Foundation, which is a nonprofit philanthropy committed to the goal of supporting implementation of health reform and to advance the effectiveness of California's public programs. I think many of you have probably attended our briefings in the past, so thank you for coming again. Just a quick orientation to your packet. Of course, we have an agenda. You'll find the Mercer presentation also included. I will not read everyone's bios. That takes up too much time, but they are in the packet for you to look at. There's also a list of relevant resources, both from the Foundation and other places that are relevant to today's discussion. In particular, there are two papers about the basic health program option, one by the Urban Institute and one by Milliman. If you haven't already read those, I think you'd find them very informative. I'd like to thank my colleague Danny Sandoval for making today very organized and make it all happen, as well as Karen Shore, who's here up front with her team from the Center for Health Improvement to make this happen, and also to Senator Hernandez and Scott Bain from the Senate Health Committee, who are both co-sponsoring this for today. And judging from the turnout and also the interest yesterday at the California Health Benefits Exchange discussion, there is a lot of interest in this topic. So quick agenda overview, a few notes from me of background, then we'll hear from Branch McNeil at Mercer for about 30 minutes. And I will pause at that point for some Q&A, as I figure there will be lots of interest in asking Branch many questions. And then we'll kick it over to our panelists. And with me today, there's Charles Bacci, Executive Vice President from the California Association of Health Plans. To his left, Rick Curtis, President of the Institute for Health Policy Solutions. Elizabeth Landsberg, Director of Legislative Advocacy for the Western Center on Law and Poverty. And John Ramey, the Executive Director of the Local Health Plans of California. One logistical note, it is being recorded, so be careful what you say, I suppose. And just some quick overview of what the basic health program option is. This is an option within the Affordable Care Act that allows states to cover low-income persons between 133 and 200% of the federal poverty level, which is the first tier of persons who would be eligible for subsidies in the exchange. For financing, states would receive 95% of the premium tax credits and cost-sharing subsidies they would have received to participate in the exchange. Beneficiaries would receive essential health benefits. Premiums and cost sharing can be no higher than the benchmark plan, which is the second lowest silver level plan, and you'll hear more about this from Branch. Individuals who, if a state were to create a basic health program, these individuals would not be able to participate in the exchange. Why did we do this project? As many of you know, we have a long list of things we do to try and support decision-making at the state level with research and modeling. This was on our list very early on, and when SB 703 was introduced, and having had many conversations with a number of you in the room, we decided to engage Mercer after looking at three different proposals, one from Mercer, one from Milliman, and one from the Urban Institute, to really address the fundamental question, which is, would it be financially feasible for the state of California to pursue a basic health program option? Of course, there are many other policy issues and implementation issues which this project did not address. We thought first, let's get to the affordability question. If it is affordable, then there's lots of other work to do afterward. But this really is just to answer the question about affordability. Oh, I wanted to make one other note that Patricia Powers, who's the acting executive interim director, I think I got that right, at the California Health Benefits Exchange, is also here to share about what was discussed yesterday at the Exchange board meeting and will participate during the question and answer. So with nothing more from me, I'd like to hand it over to Branch McNeil from Mercer and direct you to the slides and to your packet.
Thank you, and good afternoon, everyone. So I think I'll start first by just mentioning that we've got a few folks, a few of my colleagues from Mercer in the second row there that I may call on to bail me out if there are questions beyond my capacity. Jerry Smittinghoff is was our lead actuary on this. Cherie Swanson was another actuarial resource we had. And then Michelle Walker really kind of helped us out with the policy pieces of the work. So I think Len adequately covered the first couple of bullets on the first page. Let's get to kind of what the presentation is going to cover in its entirety. We're going to talk a little bit more detail about who would be eligible under the Basic Health Program, what are the requirements for the Basic Health Program, how the BHP would be financed, and then, of course, the big question is, would it be financially feasible? And then from there, of course, even potentially beneficial to offer the BHP in California. What potential impacts could offering the BHP have on the California exchange? And then some other considerations, which is kind of code for caveats, fine print. So on slide 2, this is kind of the discussion of who is eligible. So the criteria for individuals eligible is that they we have to have income up to 200% of the federal poverty level. I'm just going to say FPL from here on out probably. They have to be U.S. citizen or lawfully present immigrant, under age 65, not be eligible for coverage under Medicaid, which Medi-Cal here, Medicare, or CHIP, HFP here, and then not have access to employer-sponsored insurance, ESI, which I'll refer to again later, that meets certain standards under the ACA. And those standards are really related to the comprehensiveness of the benefits as well as the affordability of the premium levels. So it kind of boils down to two groups of individuals that will be eligible. And so it's adults with incomes between 133% to 200% of FPL. Just a quick note to everybody. 133% is really kind of equivalent to 138% after you do the income disregards. And the significance there, obviously, is that will be, in 2014, the new threshold for Medicaid, essentially the new minimums. And then the second group would be the lawfully present individuals with incomes below 133% of FPL that are not eligible for Medi-Cal or HFP because of the immigration status. Okay, so the requirements for the Basic Health Program, just run through these relatively quickly. Cover the minimum. A Basic Health Program must cover the minimum essential benefits, which is not yet fully defined. It's expected really to kind of closely mirror federal employer coverage as well as large group coverage today. Member premiums must not exceed, and this is an important part, they can't exceed, but they can be less than premiums charged for the second lowest cost silver level plan offered through the exchange. And then for individuals, and this is a little bit of a correction, right now on the slide we have for individuals 133% to 150% of FPL. It's really just less than 150%, if you want to look at it that way. The cost sharing cannot exceed platinum level cost sharing. And I've got two percentages up there because this is some of the funny business in the ACA where there's language in the exchange portion and then there's language in the Basic Health Program portion. And so it's 10 or it's 6%. Platinum is generally 10%, but the maximum cost sharing is 6% for the group under the Basic Health Program. I think that's actually different in reality, but the point is that the cost-sharing benefit will be based on the 6%. And we'll get into the details on that a little bit later. And then for the individuals in that higher group, the 150 to 200% of FPL, cost-sharing cannot exceed the gold level. And again, that's where there's a difference, 20% as well as 13%, that are the two relevant percentages there. The plan offered is either a managed care system or offers similar benefits. And so in the case of a non-managed care system or non-managed care plans, you might be able to get away with a fee-for-service program with maybe enhanced primary care case management attributes. To the extent feasible, the consumer should be offered choice of options. That doesn't necessarily mean choice of plans, but again, choice of options. Medical loss ratios can be no more than 85%. And then it indicates that plan selection should be through a competitive process. Exactly what that means is as clear as the rest of the ACA. Okay, so moving on. How is the BHP financed? Len touched on this, and we're going to talk about each one of these in more detail, probably more detail than you want. So I'll breeze through that piece, but in general, it's the two components. It's the premium subsidy, which is based on, but not equal to, the amount that the member would receive as a subsidy under the exchange for their income level. And then in addition to that, the federal government will pay cost-sharing subsidy, again, based on the cost-sharing subsidy available under an exchange. So before we get to the details, it's important to kind of keep track of the differences between the exchange side and the BHP side. They are different, and the BHP financing is based on the exchange pricing and costs and so forth. So there's a link there. You just have to kind of remember that they are separate, but there is a strong link between the two. And so the big link is the silver level plan in the exchange, and we'll talk about bronze through platinum level in just a minute. So let's actually skip to the second bullet here and do the different levels. So the different levels, bronze, silver, gold, platinum, they just are an indication of kind of actuarial value. And what people are reading that to mean is that essentially for a bronze, 60% of the healthcare costs would be covered by the premium. Therefore, leaving the other side of the premium covering healthcare costs would be the cost sharing. So in the case of the silver level benefit, 70% of the healthcare costs on average would be covered by the premium that a member would pay, and 30% would be covered by the individual themselves. So it's a little bit strange that everything's based off the silver when, in fact, the lowest income group that will be getting the subsidies will never pay the full 30%. And that's actually the group that's probably most likely to be in the exchange, obviously. So that's what, when we talk about bronze, silver, gold, platinum, et cetera, what we're talking about. So let's go up to the top there. So the premium subsidy is available under the exchange calculated as follows. So it's the difference between the ACA maximum allowable member premium based on income. So we've got 3% at 133%. Just roughly think about that as about a $50 number in 2014, give or take. And then 6.3% at 200%, that's going to be in the $90 range in 2014. So what that's saying is that that's the maximum amount that a member would have to pay for a premium for a silver level plan in the exchange in the future. And so what you do is you have to price out the subsidy is how much the actual premium is offered under the exchange versus this maximum. And so just to do an example, if the second lowest cost silver premium was $550, and you take somebody at the lower income level, and that was a $50 max that they're going to have to pay, then you're left with a $500 difference that you can base the premium subsidy on. So you take 95% of that, and you're left with a premium subsidy, in this case, just for a quick example, of like $475. So again, in this example, we just went from a $550 premium to the subsidy for that premium, which would be about $475. Clear as mud, I'm sure. We'll get we'll have some more on that in just a minute. So the cost sharing subsidy is far more complicated. To start off the complication, it's not clear under the ACA whether it is 95% or 100% of the subsidy that would be available to a member through the exchange. Just to be conservative, because this is a feasibility analysis, so our goal was to try to be as conservative and kind of safe on both sides. We just assumed it would be the 95%. And the reason that's conservative, obviously, is it gives less money in the subsidy for comparison against costs later on. So we get down to the kind of the details in the second bullet, and the long and short of it is this is where the 6% and the 13%, as compared to the 10% and the 20% for platinum and gold level, come into play. and it's really the lower income group. It's the 24% of the total health care cost piece from a silver level benefit that would drive your starting point. Then you would say 95 or 100% of that, and that would be your subsidy. So it's a pretty substantial subsidy for the lowest group, 24% of total health care costs, as compared to the 30% that in the open market exchange, well, just call it the exchange, would be paying. So that subsidy is significant and adds on to this in a very helpful way. So on slide 7, we're just going to talk about the steps that outline our approach for the feasibility analysis. And we're going to talk about each one of these in a little bit more detail, but to try to get through them briefly. So you first got to estimate the size and the demographic characteristics of the uninsured population that will be eligible for the exchange, and then the subset likely to enroll in a BHP, if that's offered, and the exchange. So just to be clear to everybody, I think that it's pretty common knowledge that not everybody who is eligible shows up for programs. I believe there's a Kaiser study out that estimates that 18 to 20% of eligibles for Medi-Cal and HFP do not show up. And that's not showing up for programs that have zero to very low cost sharing or premiums levels. So that's an important piece. The next step is to estimate the silver level benefits and the premiums for a second lowest cost in the exchange, because that will drive your subsidy calculation, calculate the resulting subsidies related to that. The second to last sub-bullet there, estimate the premiums that would be required to fund a basic health program for the population up to 200%. And so I got to pause here. And so what we say here is through the existing Medi-Cal managed care organizations. That's not really accurate, and I probably should have fixed that. It was for our feasibility analysis, we started with Medi-Cal and the data we have from Medi-Cal, number one, because we have a lot of good specific information from Medi-Cal. Number two, Medi-Cal currently covers adults. And number three, and probably most importantly for the feasibility piece, Medi-Cal represents the lowest paying kind of large payer in the state and would probably be the floor that you'd want to use in some future program, and then from there perhaps ramp it up. And so if you look at it kind of on a continuum, clearly you would have at the lower end Medi-Cal, at the upper end commercial, HFP would be in there above Medi-Cal, and Medicare would be probably just below commercial. And then, so you do all that, then you calculate the resulting difference between the two, and you have your answer as to whether it looks like it will be financially feasible. So in terms of estimating the exchange and the BHP populations, we used CPS data. We used it from 2007 to 2009 to kind of smooth some things out. So we used that as a starting point. We corrected for and manipulated the data to try to address some shortcomings that CPS data has. We compared individual components and the big picture results to a lot of other surveys and some other publications that had been done already, for example, the CHIS data, and that came out very, very close. And so we were pretty happy with that. And so I mention that just because I know that that data set is typically used for policy decision making here in California, and trying to just let you know that the answers were pretty darn close, and so we're comfortable with the data set that was utilized. Okay, so there are just assumption after assumption after assumption that you have to make in an analysis like this, and so several of those really drove where we ended up, and we really wanted to kind of make mention of those here so that you guys can agree or disagree, but at least you'll know what went into it and the thinking. Let's see. All right, on to the next one. Okay, so this is big picture. So think of like the whole pie, if you will, to start. Our estimate of the total exchange and BHP eligible population, eligible being italicized, is 4.5 million for the state of California. The table that we have here displays the estimated total exchange and BHP population that we're thinking will enroll in the exchange and the BHP combined. So if you go to the lower right corner, That's about 2.5, 2.6 million individuals. So you'll notice a pretty big difference between the 4.5 million eligible and who we think will show up, and we'll get into some of those assumptions in just a bit. But this is big picture. The two charts that we're going to see that follow add up to these numbers essentially, because we're going to do one for the BHP and one for the exchange, net of BHP. So our key assumptions that went into the exchange population, net of BHP, is that the group would consist entirely of adult individuals and families with incomes above 200% of FPL. Individuals with existing government-provided health benefits will stay there and will not be eligible and will not show up in the exchange. This is a pretty big assumption, but we feel pretty safe. It probably won't stay exactly zero, but we've assumed that the number of individuals with employer-sponsored insurance coverage will not change significantly during the implementation. Mercer does a huge national survey and with thousands of employers, large and small, nationwide, and the early indications from that are that the vast majority of them expect to continue to offer coverage in the future. And so that's the nature of that assumption. And then the last two you'll see as kind of repeats when we get to the BHP, but we're saying virtually all individuals between the 200% and the 400% of FPL level with privately purchased individual policies today will migrate to the exchange to take advantage of the federal premiums and cost-sharing subsidies, which won't be available outside of the exchange. And so that's a kind of a known group that, yeah, we're basically saying all of them are going to come in. And then relatively few individuals above the 400% of federal poverty level will enroll in the exchange. And that's just because it's a number one, a big fat unknown. But number two, if the outside market of the exchange has additional flexibility, offers different benefit levels and additional options, you know, we think that in some cases that may be more attractive to that group. So moving on, this is the exchange net of BHP specific chart. We assumed 70% of that group, the 2 to 400% group that's going to get the subsidies, would show up and enroll. And then only 25% would enroll greater than 400% of FPL. And that is really just to demonstrate that we think it's going to be, you know, something significantly less than half. Exactly what it's going to be is anybody's guess, really. One point to make here that I think is pretty valuable is that if you just look at the size of that number on the lower right-hand corner, even net of a BHP, California's exchange is likely to be bigger than any other state's exchange if they don't offer a BHP. 1.8 million is a pretty sizable group, and it will still be plenty attractive. So just making that point here. Moving on to the BHP, very similar kinds of points in terms of what we assumed. Age 19 to 64 with incomes up to 200% of FPL. The children up to 200% of FPL will not be involved in any way, shape, or form. They will be eligible for HFP or Medi-Cal. Legal immigrants with residency status less than 5 years, below the 133% of FPL will be eligible for the BHP. And then the individuals with existing government coverage will not be in. The number of individuals with ESI, that's the repeat bullet, and the last one is kind of the same repeat bullet. It's just applicable to the BHP piece, which is that most everybody with ESI at this, or I'm sorry, privately purchased below 200% will show up in a BHP option because of the benefits they get through the subsidies. So the result of that is the chart on slide 13. So probably a real good time to just pause and emphasize this point. So here in this group, we assumed 70% of the BHP eligible group would enroll. That 70% is very heavily dependent upon the size of, or the level of premium that would be charged through a BHP option. So one of the attractive things about a BHP is that you can offer lower premiums than would be available to these low-income individuals through an exchange. And so we've made some assumptions. I think we have a $10 and a $20 assumed premium for this group. If that premium is lower, you might even be able to achieve higher penetration. Higher penetration being more than 70% of the eligibles will show up, that would be better risk. At the same time, if you go much higher than the 10 and the 20 and you're pushing close to where they would have to be under the exchange anyway, this will fall off sharply, maybe 50, 60% or even less potentially, which would actually drive the risk up. So these assumed percentages of folks who show up are really critical in kind of the ultimate feasibility analysis. Let's see. Just the other point here on the average age, the right-hand column at the top there, the average age here for the BHP group, 40.8 years, compared to the average age expected for the exchange net of BHP group was 40.6. So they're virtually the same. It is really very close. And frankly, we were surprised about that, but that was what the data showed. So then you get into the steps for estimating the silver level benefits and premiums. We priced that based on, we have a proprietary uninsured model. That model is populated with national commercial large group data. We adjusted for California-specific factors. It actually is largely populated with California anyway because of the Pacific influence. We projected that commercial cost and the utilization trends at each category of service level kind of forward to the 2014 point. We then took the BHP subsidy calculation from the second lowest silver cost plan. So we've got a funny kind of statement there, which may understate actual risk. So if you've got so California's going to do selective contracting for their exchange, whatever that means. But I think what it means is certainly it'll be limited. And how limited is a question. But let's just say you have 10 plans, which probably is not realistic for California. But those 10 plans will have 10 different rates that they'll be offering if it's kind of free market within the exchange that way. And so just kind of the natural thing is you're going to have high and you're going to have low, and so you're going to have to base it on the second lowest. As everybody's shooting for the right mark, they're trying to come close. They've got their limits. Some people are going to understate the risk of the exchange, and so that's kind of the point of that one. So the second lowest cost probably may just fall short of the actual risk of the exchange. That will all be self-correcting over time within the exchange as actual experience is demonstrated there. Okay. We did not add any uninsured risk or pent-up demand to this side, and that was very much conscious effort on our part to be conservative, because if you add an expectation for higher risk, pent-up demand, et cetera, then you build up this side of the equation, which then you're using that to calculate your subsidy. We assumed the younger ages would be less likely and older ages more likely to enroll. We did that for conservatism, so I think we said 70%. And I think in this one, the 70% was really kind of made up of like 60% for the lower group and 80% for the higher age groups in the exchange. And then we did not make a specific adjustment to expand the average commercial benefits to essential benefits, number one, because that's not 100% defined yet. And then also, again, kind of for conservatism, because if that's going to do anything, that would be an upward adjustment, and so a little bit more conservative to do it this other way. This slide's a bit of a mess, but let me take a minute to point out a couple of things. So the first bullet, and this is an important concept, we're saying that the total health care costs for an adult, non-family, within the exchange is projected to be $593 per member per month. That is not the premium. That is the total health care costs. So if you take that and you say that 30% of that is going to be member cost sharing, 70% for the silver will be paid by the premium, then you have to add on an assumed administrative load, and the load that we assumed was 15%. So that's kind of what the other numbers on this slide are about. I'm going to skip over it and get to the table on the next slide 16, which really kind of gets at the answers. So based on the exchange premium cost sharing estimate, the average federal subsidies available are calculated in the table below. So we really use the exchange demographic profile. It says BHP, but exchange demographic profile to get the weighted net federal BHP premium and cost sharing subsidies. And if you work your way down, so the premium itself, remember how I said in the previous page that higher number was not the premium. This would be the premium. You take that premium, you pull out your estimate of the premium offset or the maximum premium under an exchange. The difference is the net premium, and you calculate your subsidy off that. That's the 95%. So those numbers are bulleted. Bolded. I'm sorry, the 95%. So it's 411 at the cheaper group, or for the the lower income group, and then the higher group it's 375, which is a good point to just demonstrate that clearly the subsidies lessen as income levels go up. And then further down, you'll see that the 95% of the cost-sharing subsidy is significant, as I was pointing out before, the $135 per member per month and the $96. And so the total estimated BHP subsidy is $546 for that lower group and $471 per member per month for the 150 to 200% group. So that gives us one side of the equation, which is how much will the federal government pay the states to do this? So slide 17. So where we use commercial data as the base to kind of build up for our expected exchange cost, and which of course drive the subsidy. Again, as I mentioned at the beginning, we use the Medi-Cal managed care encounter data as well as fee-for-service data for the adults. We split up in 10 different age and gender groups for two categories of aid, really the family category of aid, which is kind of a TANF-related group, if you want to look at it that way, and then also disabled group. So this was very conservative on our part, the middle two bullets there. So we blended the data together based on the member demographics that exist in that we're projecting to exist in the BHP. We left in, for that blending, 20% of the population as disabled. In reality, if California doesn't change their eligibility rules and so forth, the likelihood is that it'll be quite a bit less than 20% of a disabled kind of looking population in terms of risk. And so, again, this was just a conservative move on our side, trying to build up the potential cost of a BHP. And then likewise, we kept the Medi-Cal maternity experience in the rates, which is very significant and much more substantial than it would be in a commercial. I think it's pretty common knowledge that, roughly 45% of all births in the state happen through the government-funded programs, whether it's Medi-Cal or the AIM program. So it's very significant, and clearly the group above would not be expected to have that. But we left it in, again, for conservatism. One thing that we could have done for conservatism that we didn't do, but we think balances out pretty nicely, is just adverse risk. If you're going to have only 70% of the people show up, probably your very cheapest group is going to be in the group that doesn't show up, and your most expensive groups will almost certainly be overrepresented in who shows up. At the same time, the Medi-Cal experience data does not have any effects of any kind of member cost sharing. And so that member cost sharing, number one, offsets costs, and number two, it also kind of affects utilization in a positive way from a cost perspective. Some would argue a not so positive way from a care delivery perspective. So then we trended all that forward to 2014. We assumed an administrative loading factor of 12% here, including the profit risk contingency. We think that's a pretty darn safe assumption for loading under if it were a government-sponsored or delivered program. So moving on to the bottom line that many of you, I'm sure, tuned to long ago, is the so we assumed the 10 and the 20% premiums. Again, that's really important. That's nice and low, but we assumed that for purposes of making sure that we had adequate enrollment in there. And then we assumed a very low 2 and 4% cost sharing, which is pretty close to what HFP cost sharing would be today. And the bottom line here is that the net BHP costs are, $393, $382, and kind of a weighted average there of $385. So moving on to the next slide really gives you the final answer, which is that there is an excess, a projected, estimated excess in terms of what the federal government would pay the state for a BHP population or program versus what it would cost the state to run one at the reduced provider rate or reimbursement rates that exist under Medi-Cal today. And it's a pretty substantial difference, as you'll see. And so, kind of just getting to the conclusion there, really, if you wanted to, so I should probably back up and say, to the extent that there is this excess, that is not, hooting and hollering time for the California budget. It doesn't do anything. The state can't keep that and use it to take that extra money and do anything with it other than for the benefit of the BHP itself. And so the options there, of course, would be to reduce member cost sharing, to reduce premiums, to increase provider reimbursement. Some combination of all of that appears to be potentially eligible based on the estimates that we've got here. And so just based on this estimate that we had on the previous slide, which we think is pretty conservative, it really could kind of go either way. But we really do think that it's conservative, and so the gap might actually even be larger. And we think the biggest conservative side would probably be the basic health program side. We think the cost probably could go down pretty substantially, again, for the two reasons we mentioned, the maternity experience and the high disability representation in the data that we used. And so that's significant, and I'm sure we'll have some discussion about that. The other piece that is on folks' minds, I'm sure, is, okay, so we do all this. How do we pay for it, the administration of such a program? And what the point we're making here is I don't think it's 100% clear in ACA that any of that money, that subsidy money, can be used for administration. I think it's just silent, if I'm not mistaken. So it doesn't say you can, and it doesn't say you can't. And so that is something that may come out in regulations later. But the bottom line here is just 1%. If the number of folks show up that we've projected at the costs that we've projected, 1% is $42.7 million annually. At 2%, it's $85.4 million. And so the reason we're putting those numbers out, and just to give you a sense of things, that should be plenty to run a basic health plan, basic health program option in the state if it is attached to an existing program. And what I mean by that is if it's not a standalone operation that needs to have all of the fixed costs, sticks and bricks, staffing all by itself. If that can be shared and tacked onto an existing program, my gut certainly is that would be more than adequate and might even be a place the state wins a little bit. Okay, so another piece that we were asked to kind of look at and consider is the potential impact on the exchange population if you pulled out the group for a basic health program, and so then what happens to the exchange itself and the group that's left in the exchange. So the first thing that I think is really pretty obvious, at some point, I think it's January 1st, 2015, the exchange has to be self-sustaining, so it has to pay for itself, has to cover all of its own costs. And so by removing, I think we've estimated 700,000, clearly you're taking some people that you could spread that cost over out of the mix. More is always better, but at over 1 million, I think it was 1.8 that we really estimated, it really shouldn't be a game changer. It shouldn't be much of an issue at all. It's easy for me to say, I'm not paying for it, but in all reality, most states will be dealing with exchanges, in the low hundreds of thousands, and they should be able to make that work just as well. Okay, a couple other things. The BHP, in addition to the exchange, will impact the risk. It will impact the risk pool of the exchange population, pulling that out. There's just no question. So there's arguments about whether it'll increase the risk in the exchange or it'll lower it. I've kind of highlighted one of each. On the face of it, you might think, okay, the exchange risk would increase because the less than 200% of FPL group must have a lower age mix, which typically is less risky. Okay, well, actually, that's not the case. I think I pointed out earlier that the average age in the two groups is almost identical. And so that one is kind of bumped to the side and would be trumped anyway by the lower point, which is with the lower premiums and the cost sharing in a BHP, that's going to attract more people in the BHP. So that's the 70% that I was talking about. And so they're going to have a risk that's going to look like, you know, whatever that risk looks like. If you left that group in the exchange, at the exchange premium levels, the risk of that group that would show up, first of all, it wouldn't be 70%. I can guarantee that. You know, if you're moving from a $10 premium to, you know, a $50 or a $90 premium, there's going to be a big difference in the number of people who show up. And what that means is the fewer people who show up is going to drive further adverse selection, which drives up the risk, which drives up the cost for the entire exchange. So pulling this group out, I think you can have a decent argument to say that actually it improves the risk of who may show up in the exchange. Or at least that's the theory. How about that? Another couple of items to mention. By having the lower premiums in the BHP and having a BHP at all, you're really pulling that lowest income group out of the exchange. They have the least, by definition, discretionary income, and so they're going to have a higher lapse rate in terms of paying premiums and people being kind of moved off or disenrolled and then coming back when they have an issue in the exchange. And so we've just, you know, kind of mentioned that that's policy persistency. So you're going to have better continuity there. The other two bullets there in the middle, reducing the complexity of cost-sharing subsidy and simplify pricing, those are kind of just actuarial headaches that will be reduced a little bit. And then I expect there'll be some pretty good additional commentary by the panelists and maybe questions by the audience on this topic. And then last, this is just some caveats. But I think they're really important, and I just want to take a minute and kind of go through them. There are just countless uncertainties about the healthcare marketplace in 2014 that we had to make assumptions on and so forth. And so everything in here is, you know, you have to be pretty cautious with. Again, we tried to be extremely conservative, and the results still came out pretty positive. But there's uncertainties with ACA itself. Key terms and provisions in the law remain undefined or unclear. Key terms and provisions in the law actually conflict in some cases. Many decisions that have to be made as to how the state would structure a BHP and how the exchange will actually run. Both of those will have a real significant impact because, as we kind of mentioned earlier, they're somewhat joined at the hip. You've got the exchange on one side, and whatever happens here in terms of risk, up or down, you know, if somehow fabulous risk enters the exchange, that actually hurts the BHP because you have lower subsidies to pay for the BHP side, which is kind of a funny thing. You also have this just uncertainties regarding health insurance carriers, how they're going to act under ACA, who will play in the exchange, what they'll offer outside of the exchange. And then obviously probably the hardest thing to predict would be the consumers' behavior under the health reform in 2014 and beyond. So that is it. Oh, there is one thing to just mention. So with all these caveats and some of the clarification that might help would be coming out in regulations. The latest word is that the regulations that are expected to come out late spring, which probably translates to late June, is not expected to have anything on BHP. So they'll have to stay tuned, I guess.
Thanks, Branch. And I just wanted to reemphasize the thanks. Branch and his team did this in a fairly short period of time and had to be receiving emails from me and from Scott Bain and many of you who sent them to Scott and sent them to me to ask lots of difficult questions of Branch and his team, and they were great and answered almost all of them. So I appreciate the speed with which you did this and the clarity. Even though it's sometimes clear as mud, this is actually really well done. I want to, before we move to our panel, I know there's probably several questions, and I want to limit it to 2 or 3 questions of Branch specifically about the data and the approach, and then we'll move to our panel. So does anyone have questions? And Danny Sandoval will come to you with a microphone.
all at once. Okay.
That must have been one good presentation then.
Danny? Also one
yes, I had a question for Branch. How did you arrive at the conclusion that such a small number of people at 400% FPL would participate in the exchange? I think your figure was
25%.
Yeah.
So I think that that's pretty widely held thinking, is just that the highest penetration group in the exchange will be the group that's getting the subsidy, whether that's 0 to 400 or just 200 to 400% of FPL group. And that is really just because the other folks outside of, beyond that are not getting a subsidy, they will have the free market, today's commercial benefits, and whatever will be offered in the future outside. Kind of by definition, if it's the same plan in and out, they have to be priced the exact same. And so there would have to be some benefit to get somebody to go in. There may be some additional flexibility outside the exchange, some more creative ways, and kind of bottom line, probably some lower pricing for some folks, especially at those lower income levels, which 400% is not a low income level, but it's they still have limited discretionary income, and so they're going to want to pay as little as they can for their health care. So that was the logic behind it, and there wasn't any science to 25% specifically, as much as we wanted to demonstrate that we thought it was going to be less than half.
And then one question in the back, please.
Sure. I just want to thank you for an extraordinarily clear presentation given the subject matter. And I wanted to ask, you provided an analysis that suggested that it would be possible for the program costs to be quite a bit less than what the subsidy is. But is it possible, for whatever reason, spike in medical utilization or what have you in a given year, that the cost of the program would be greater than the amount of money that we get to the federal government? Is that possible? And if it is, who is in fact on the hook for paying for that difference?
It's a very good question. So in one of the other papers, I think it might have been the Milliman paper that Len referred to, I think there was a good kind of commentary in there about it's a risk reward, or it's a risk decision that the state has to do. And so they kind of encouraged each state to have some work done on their situation and what they were trying to achieve, and whether it looked like there was, I'm just going to use the term clear daylight, which I think, the bigger that daylight or that difference is, that lowers the risk. So to the extent that it's a prepaid managed care program in some form, and in California, HFP has managed care in every county, and Medi-Cal has it covering, I think, 91% of their population is in counties where they offer managed care. So to the extent that it's prepaid and you're setting rates and you know what the federal government's going to pay and you're able to estimate what you're going to pay out, I would say the risk is next to nothing. To the extent that you've got more of a fee-for-service program and more variability there, or you offer greater maybe stop-loss mechanisms within a BHP, then there's more risk for sure. It appears to be pretty low risk for California, but any given year, it might happen. And so it's a great question, and a point I wanted to make. There's the whole take-up issue. Okay, so we really did our math on this whole group coming in, almost like day one. The reality is that there would be some ramp up. California has a lot of data and can reach right out to a pretty good portion of these people. If you think about it, the HFP kids, these are their parents by definition, some of them. You've got folks in FPAC that the state has information on and can reach out to, and for a good outreach effort to maximize take-up. But that take-up period is certainly a place where you could have some risk. Another interesting thing that affects the risk is the state gets the money all up front and then gets to use that and pay that out, and then there's a reconciliation done after the fact. It's kind of funny to me that the federal government's going to make a big lump sum payment to the state. I'm sure the state would like to sit on that money for a while.
Any other questions before we move to our panelists? Great. Thanks. Both great questions. So we tried to assemble a panel that would represent many of the different views and constituencies that would have an interest or be impacted by a basic health program option in California. And we'll start with Charles Bacci, the Executive Vice President of the California Association of Health Plans. Charles?
Well, thank you for inviting me here to dance like a cat on a hot tin roof about this issue. I'm Charles Bacci with the California Association of Health Plans, and we represent 39 public and private HMOs in California that provide coverage to 21 million Californians, over 4 million of which are in Medi-Cal managed care. And while we represent all of the HMOs in California, including public plans like the county organized health systems and the local initiatives, I've been asked today to just talk about the viewpoints of the commercial health plans on a state basic health program. This is a complicated issue for us, and we've really had to stop and think about the various implications both in the public program side and on the exchange moving forward. And if I had to characterize the positions of the commercial plans, first I'd say they don't all share the same viewpoint at this point. I'd say there's three positions. They're supportive, concerned, and curious. Unfortunately, it's unclear in looking at this report that there's enough information provided to change many of those positions, although I'll be obviously talking with our commercial plans in the future. So why the diversity of opinion? First, we have commercial plans who are solely work with the state of California to provide coverage through public programs. So for those plans that are heavily into Medi-Cal managed care, they're going to view the state basic health plan option as through the similar lens as the COs and the LIs and say, well, how does this compare to Medi-Cal? We know what Medi-Cal is. We're trying to survive with those reimbursement rates. We have strained networks. If this pays more than Medi-Cal, then therefore that would be a good thing for the safety net. So clearly the details in this report are not going to change their minds because it looks like, at least at this preliminary junction, it is better than Medi-Cal. Secondly, we have commercial plans that mostly provide coverage through the commercial market. They have almost no involvement with the state of California in Medi-Cal managed care, maybe a small line of business in healthy families. The plans may be for-profit or not for-profit, but their biggest focus between now and 2014 is really on the commercial health insurance market. And that focus is on guarantee issue, community rating, the effectiveness of the individual mandate, and the volume of lives and what those lives look like in the exchange in 2014. So for these plans, it's vitally important that that in 2014 that healthy Californians are buying coverage through the insurance exchange. If they don't, and the risk mix of folks purchasing coverage in that exchange is unbalanced to those with pre-existing conditions, the entire commercial market could collapse. So for these plans, the most important question isn't how a basic health plan compares to Medi-Cal. Their most important question is, will moving these 725,000 lives, or 30% of the eligible exchange population, out of the exchange increase premiums for those in the exchange and create a death spiral? And while this report looks at the age range of these eligible individuals as a proxy for health status, I doubt that the commercial plans are going to find that to be a robust enough analysis to make a judgment call, because you really do need to know what the actual health status of these individuals are. So these are the plans that I would characterize as concerned about the basic health plan. And then lastly, we have commercial plans that do both. They do state programs work. They're major partners with the state of California on Medi-Cal managed care. And they also have robust market share in the commercial market. And so they're torn between those two calculations. It looks like it's better than Medi-Cal. What does that mean? And what is its impact on the risk mix in 2014? So it's a very, very diverse viewpoint, and we're going to continue to have conversations. We appreciate the work of the Mercer folks and the foundation for sponsoring this. I think it has answered some questions. I think the most pending one, obviously for the commercial plans, is really going to be that risk mix and what is the health status of these folks being removed from the exchange. So I also have some questions that I think are likely to come up from the commercial plans, and so I'll just throw them out here really quickly. One, how confident, and you don't have to answer these now, I think in the future it would be nice to know, how confident is Mercer in the Medi-Cal encounter data that you used? We constantly hear complaints from the department that they don't have good encounter data, so we are curious.
I can answer that one real quick. So we didn't just take it at face value. We took it and built it up for any shortcomings in terms of accuracy, missing cost data, missing encounter data. We feel very confident in that piece, that we've built that back up appropriately to be a good representation of total costs of the current Medi-Cal program and their subsets.
And the other one, of course, is did you look deeper than age into the risk mix? Obviously, in the slides, you don't show that, and I think that's probably could be in a report all on its own. And then finally, your report states that reimbursement rates for providers could be 20 or 25% higher than Medi-Cal, and I think one of the first things that popped into my mind was where does that rank with Healthy Families, Medicare, and commercial reimbursement rates? I'm guessing it takes it up to Medicare roughly. I don't know if you've looked at that.
It wouldn't actually take it all the way up to Medicare, but it would improve it. I guess I'd go back to the very conservative piece. I actually think you might be able to achieve more. But, if you think about it roughly, depending on the study and depending on the specific category of provider group that you're talking about, I mean, Medi-Cal can be anywhere from 50% to 60, 65% of Medicare. And then you got to think commercials even above that. So there's a pretty good distance between them currently.
Thank you. And thank you for the opportunity to present today. Appreciate it.
Thanks, Charles. Appreciate your comments. Rick Curtis from the Institute for Health Policy Solutions for the 29,000-foot view level. Thank you.
Actually, I'm not going to be able to help go down to 10 feet on one or two things here. This was really a very, very good and careful analysis, and I think the degree to which you were straightforward on the assumptions and how they drive things is very admirable. There's one point, I'll get back to that, where I'm not so sure the assumption was conservative. But at the 10,000-foot level, the whole purpose of this option for states, as you know, is essentially comes down to, well, if you could pay plans less in a public program arrangement and use the savings to reduce costs or improve benefits, that's also an option for folks. And a state wants to do that for 95% of what the tax credit expenditure plus the cost sharing fill-in would otherwise be, that's an option. And clearly, given your Medi-Cal reimbursement rates compared to any estimate of what commercial rates would be, suggests there's a lot of room there. There are a lot of systems implications that people in the room here understand better than I do, but there are system implications here. So that's what this shows is, in fact, California appears to be in a position to use this option. And as Branch more cryptically mentioned, of course, there's this real concern about the people above and below 138% and their incomes changing and having to change providers and plans. And having this program in place should help to address that issue. On the other hand, obviously, what this does is then increase that level at which you have that happen to 200% of poverty. In general, income fluctuations are greater the further down the income stream you go. They're certainly greatest under poverty. I don't know exactly what they are around 138%, which happens to be about where a full-time minimum wage worker is. But because it's about where a full-time minimum wage worker is, it could be that there's a little less fluctuation around that point than 200%. I don't know. So another issue is, unless this were purely a sort of an extension of Medi-Cal, if it's in any substantive way different, 138 to 200% of poverty is a very narrow income range to have a substantially different program. And I think that mitigates somewhat the attractiveness of this option. And further, there is the issue you're all aware of, that Medi-Cal provider networks, as was mentioned, are pretty damn thinly stretched now. And there's a real question about what the effects would be of even more greatly expanding the population served by them, especially by a program that now pays them more than they get paid under Medi-Cal. I could imagine in some circumstances that would further diminish access for the Medi-Cal population. There may be policy levers that could be pulled to reduce that effect, but I think that's a real concern. With respect to the effect on the exchange, which is sort of the reason I think I was asked, Pat Powers asked me to substitute for, the way we look at it is that the exchange core population, the people that come to the exchange to get the tax credit, is the only population you can really rely on, and as Branch more carefully said than I'm going to say it, anything else is a crapshoot. So what we really focus on is what happens to that population, and the Mercer estimates are that would go down by about a third. And the Urban Institute, if you look at their estimates and extrapolate from them, which we've done, it would say it would go down by about half. Those are both very substantial reductions in the core population. If the urban numbers were right, it would bring the core population of the exchange down to about 25% of the estimated total individual market. And that becomes, I think, a different ballgame in terms of what the exchange's role is in the individual market. And how attractive it is. And one of the many areas where there are critical assumptions here that drive the numbers has to do with the premium, as Branch said, and it sounds like they did a good job of carefully thinking about it given their numbers. But that premium number, as Branch doubtless knows, is quite high compared to the CBO estimated number. And based on MEP's employer surveys, I don't know about yours, employer premiums here are, which should be pretty representative of what's going to happen under reform, given all the various measures there, are virtually identical to national premiums. And we believe that the CBO numbers are reasonable. If they're not, there are all sorts of implications here for the implementation reform. If the costs are this high for the second lowest premium plan, we got a huge problem with people just over 400% of poverty and their affordability. That part's real obvious. We got a huge problem with federal costs being, I would just make up a ballpark 25-30% higher than have been estimated to date. That's a huge problem. I think that because there's individual choice and there can be narrower networks available to people that they can choose the one with their provider in it, and the ACO movement, you can see that with the effects with your CalPERS Blue Shield initiative with the physician group, the Hill group, and the hospitals here in Sacramento. I think there's good reason to think that the second lowest cost silver plan is going to be substantially less. Now, if that's true, one obvious implication is then the amount of money you have to deal with is a lot less, but profoundly less, 20% less about. But secondly, and this is very important to bear in mind, the way, and Branch did the best job I've ever heard of describing how these tax credits are calculated relative to premium. Well, at the CBO estimated level of the second lowest cost silver plan, the people in their 20s and early 30s don't get a tax credit if their income is above around 275 to 300% of poverty. At his assumed premium, they disappear around 350% of poverty. Why is that important here? Well, for the following reason. If CBO's number is right, then, and urban estimates are right, and I think they probably are, then you'd have a huge reduction in the number of younger people, younger adults, who participate in the exchange because of the core population, you'd only have that fairly narrow income range left getting the tax credit and eligible for the exchange. And that would change everything here, including how attractive the exchange was for his members to participate in. So if you have a greatly diminished exchange in terms of its core enrollment, and you have a much lower proportion of young people on whom, given 3-to-1 age rating, plans lose money, make money. They lose money on the older people. It really changes the ball game. And I think nobody can know where that second lowest price silver plan is going to be, but there are all sorts of implications if it's different.
Thanks, Rick. Elizabeth Landsberg for a consumer perspective.
Thank you also for the opportunity to present and to give a consumer perspective. Western Center is intrigued by the notion of the basic health program if first it can in fact offer the same or better benefits with lower cost sharing for these low-income folks, and if it's adequately coordinated as seamlessly as possible with the Medi-Cal and the exchange. I just want to sort of bracket a couple consumer advantages to highlight initially. Something that Branch mentioned but that I wanted to highlight is that in the basic health program we can get federal funds for all legally residing immigrants. So that 5-year bar, which means we can't get federal funds for that population under the Medi-Cal program, we would be able to draw down federal funds for that population in California under the basic health program. As Branch mentioned, there would be some simplification involved with having a set premium level, more like Healthy Families does it, than this widely varying percentage point, which is complicated. Also, I think importantly, consumers in the basic health program wouldn't be subject to tax reconciliation penalties, which I think many of us are aware of are going up. There's going to be a process at the end of the year, and if your income has gone up and you've been getting a higher level of exchange subsidy, there will be a reconciliation process and a penalty process, and we are concerned about the impact of that on affordability for consumers. So those are some advantages for consumers of the basic health program. In terms of our basic question about whether the numbers pencil out, this was a very helpful analysis from Mercer, and we are encouraged by the numbers presented, perhaps a little less so after Rick spoke, but when I read it last night, it looked good. But we wanted to sort out what the numbers mean for real people. So I only have 40 copies of this, but if Danny or someone wants to hand these out, I just tried to do a couple of scenarios for what the real numbers would look like for people. I don't know if someone wants to hand it out or... So someone at 140% of the federal poverty level in the exchange has to pay 3.4% of their income in premiums, which is $43 a month, and has to pay 6% of the health benefit cost in cost sharing. Under the assumptions here in the Mercer study, they'd be paying 10% per month in premiums and 2% health benefit costs. So that's a huge savings for folks. We're even, in some ways, more concerned about the 200% federal poverty level, the top of that income, which will have to pay 6.3% of their income in premiums in the exchange, which is $114 in premiums. I did FPL numbers for this for 2011. I know Branch was looking at 2014 numbers. That person at 200% of the federal poverty level, which is only $21,000 a year, would have to pay 13% of the health benefit costs, whereas in the basic health program assumptions here would pay $20 a month in premiums and 4%. So the basic question of is it more affordable for consumers? If these numbers pencil out, it's very encouraging for consumers because we are very worried about the high costs for this low-income population in the exchange. In terms of the assumptions underlying the numbers, and I agree it was very helpful how clearly you laid out the assumptions, we thought the take-up rates were reasonable. We think it's rightly optimistic to assume that if California does a good job with outreach and education, which we all need to work on, that we'll get to a 70% take-up rate. It's a similar number that you see presented yesterday, and so that seemed reasonable to us. We appreciated that you used data from a mix of Medi-Cal populations and that you included some folks with disabilities in the mix. We are, as others have expressed, concerned about starting with the Medi-Cal managed care rates as the starting point. So while we appreciate that the conclusion was that we could pay providers 20 to 25% more than Medi-Cal rates, it would be helpful to see the full budget because at this point we have a set amount that the basic health program would cost. We have a possible increase for providers, a possible 1 to 2% of admin costs. But we fully recognize that paying the Medi-Cal managed care rates is not an option, as others have spoken about. I think the Medi-Cal provider network is really at a breaking point. We'll be adding 2 million plus more people into Medi-Cal as it is with the Affordable Care Act expansion. So it's just not sustainable to think about adding the basic health program population as well. So I think at a minimum we'd need to see that 20 to 25% increase in provider rates. And I think our safety network is somewhat strained. In addition, the waiver right now is bringing in some important resources, but we need to ensure that whatever network we use to offer services through the basic health program is sufficient to ensure the access to services that people need. So we've talked about some of the advantages, and if the affordability is there, our other main concern as consumer advocates is that the basic health program has to be operated as seamlessly as possible with the other public programs for Medi-Cal and the exchange. And so to maximize that coordination, we would urge that the basic health program be administered by one of the agencies administering that program, either the Department of Healthcare Services or the exchange. As Rick talked about, people at this low income level have very high income volatility. We know there are going to be a lot of people moving between the basic health program and Medi-Cal and vice versa. So because of those frequent transitions, we think it makes sense to have the program administered by the Department of Healthcare Services, to try to have as much overlap as possible between the Medi-Cal managed care plans and the basic health program plans. We recognize, of course, that there are many counties that are still only have Medi-Cal fee-for-service, and that there are the COES counties that only have one Medi-Cal managed care plan. The federal law does encourage competition, and so we need to figure that out. But we think for coordination, there is a lot to commend itself about having the department run the basic health program. Other consumer advocates have raised the concern about taking the basic health program population out of the exchange, the impact that has on the risk mix, the impact it has on the purchasing power issues that Rick has addressed, and those are also, of course, very important considerations. And then regardless of which department runs the basic health program, we need to make sure that we have an eligibility, enrollment, and retention system that works seamlessly between programs so that people can fill out one application. Folks can't need to know what program to go to apply for. We've got to help them get into the right program. And then we have to make sure that the transitions between programs are seamless, that people don't lose coverage between programs. SB 703 does envision having continuous eligibility for a year, and we think that makes a lot of sense. So we're cautiously optimistic about what this would mean for low-income consumers and look forward to continuing to be part of the dialogue. Thank you.
Thanks, Elizabeth. John Ramey, Local Health Plans of California and sponsor of SB 703, and 5 minutes so we can get in some Q&A, please.
That's easy. I'd like to express our appreciation to the California Healthcare Foundation for doing this work in such a timely manner that will actually allow the work to be useful in the development of public policy, which is what foundations should do. And also very appreciative to Mercer and to Branch and his team for using the knowledge that they have about California and to doing it in a timely way that offers a really lot of substance to our discussion about the policies that we are developing. I realize that in my life I spent a lot of time trying to figure out why Branch is wrong about things in terms of the Medi-Cal managed care rate. And I'll tell all of those of you who are out there trying to think of ways why he's wrong right now, it's not that easy. It's a pretty hard thing to do. I think that my comments are really threefold. One is there's a lot of daylight here, I think, that has been established. Even if the assumptions are off by quite a bit, there's still significant daylight. And so those who would like to raise the bugaboo of, well, this could possibly cost the state general fund some money, I just don't think that the numbers hold that up, that there are ways to administer this program with plenty of safeguards, that there will be no state funds involved, and it could be done in that way. And so that would remove a significant obstacle to California adopting a basic health plan. Secondly, when you just think about it, $180 per family or per person contribution in the exchange versus $21 in the basic health plan. How could we not adopt a basic health plan with those numbers? Even if they're off by half, and that's 90 and 50, it's still a reason why we have to do it. because these families are not going to be the ones that are going to be stepping forward to buy health care coverage in a culture of coverage which we desperately need to establish if they can't afford it. And this would be a way to make it so much more affordable for those that can least afford it, but get them into the culture of coverage and thereby lower costs for everybody in the system. Last, the blend of Medi-Cal funding that could be established, or, Healthy Families Medi-Cal being approximately the same, perhaps with Healthy Families being a little bit higher. But the point here is that I don't hear many other proposals that we're talking about these days to get Medi-Cal or Healthy Families funding up by anything. I mean, the discussion that Branch and us are going to be having for the next few months is going to be how that's going to be reduced, not increased. And whether we're adding the populations required in the ACA to Medi-Cal or not, and I know that there's provisions for the primary care funding to be established, but it's only for a short period of time. It's not permanent. I don't see this Congress like making those things kind of permanent. Where else are we going to get a boost for our Medi-Cal providers? And it may not be as much as we want it to be, but in the blend of their funding sources, I think that this additional 20 to 25% could really be significant for a pretty significant population of over 700,000 people. Like Rick, if there's one thing that I hope Branch is wrong about, it's how much care is going to cost, or coverage is going to cost in the exchange. For the sake of health care reform, we all want that number to be as low as it can be. That doesn't necessarily help the idea of a basic health plan, but there's plenty of margin here, and I just don't see the reasons why we shouldn't do it. And our members are really feel very strongly, but for the benefit of our safety net provider networks and our beneficiaries and the poor and the near poor, the working low-income folks, this is definitely something that needs to be done for California.
Thanks, John. And before we open it up to all questions, I wanted to offer Pat Powers a few moments to say anything that she would like based on yesterday's discussion at the Exchange Board meeting.
Thanks, Len, and thanks to all the panelists and to Branch and Mercer for an excellent study. It was very interesting. Many people in the room and some of the panelists attended the Exchange Board meeting yesterday and know that we're just getting up to speed on this issue. We had a very skeletal discussion. A lot of concerns were raised, and I think Rick and Elizabeth and in part Charles raised some of the concerns that the board raised yesterday. One of the questions they had is, our understanding is that this program is based on the state of Washington, and that Washington has not decided whether or not their exchange will incorporate their basic health plan. So I didn't know, Branch, if you have any information on what's happening in Washington, but I'll let you answer that. I just want to say that the board, I think the message from the board is to proceed slowly. We want to really understand this. We want to understand the implications on the risk pool, in particular of the exchange, as everybody talked about. And are there other options? What if this basic health plan option were in the exchange or Medi-Cal? I know Mr. Mibb is an option, but we really want to just exert caution, especially given your last slide that presented all the unknowns.
Right.
Thank you.
Absolutely. I should just reemphasize that, all of this does have to be taken with the knowledge that there's so many unknowns, and nobody has the answer or can exactly project the answer. We tried our best to be conservative and to move forward that way. Probably the bigger area of conservatism was in the cost of the BHP side, as opposed to the exchange rate side. I don't know exactly what Washington's doing. I would ask Cherie if you've heard anything. Cherie actually helped work on the Washington exchange when that came up, or the basic.
I'm not currently involved with their decision making. My experience with the BHP was several years ago, so I don't know if I can answer the current question other than that right now in Washington there's a limit on enrollment because of the limit on funding. So I don't know about their current considerations.
One other thing that I don't think we really mentioned too much, but probably should be put out as another consideration, and this is not clear, but because there are maintenance of effort requirements under ACA, some of the existing populations under Medi-Cal and other government programs, if they go above and beyond the current minimums, and even they go above and beyond the future minimums, to the extent that those individuals were dropped and the eligibility changed there, this would be a way to catch them. That is the one place where, if allowed, and I have to emphasize that I'm not sure that that's allowed yet, I'm not sure that anybody knows, that would be a place where the state would actually score some real general fund savings, because the cost would fall to this program, which would be entirely federally funded, and the state share for that group, whether it's they're paying a full share or even just the state portion, non-federal portion, that would be some actual savings. But again, I think that's got to stay tuned and find out what comes down in terms of regulations and interpretation from the federal government on that.
Thanks, Branch. I'd like to open it up for questions and comments for Branch or any of the other panelists. We have about 7 minutes remaining. No questions at all. I find that difficult to believe. But Rick Curtis has a question. Oh, I'm sorry. Is there one? Oh, I'm sorry. Yes, please.
The name is Ralph Ochoa. I'm with the law firm of Ochoa and Moore. And my question is that since the language, the phrase's description is coverage to basic health care, and California itself is 17,000 physicians short of where it ought to be, and that proportion of the dearth of physicians to the population goes across every state in the nation. So if you're adding this number of persons, and we already know what the burden is, not only with doctors but other health professionals, what are we doing other than exacerbating the existing problem?
Great question. Huge issue. Probably not the right place to get into capacity issues here, although I should say that I know the Center for Health Improvement is planning, I believe, a workforce capacity and scope of practice briefing in the coming months. So I would invite you to come to that, and you'll hear lots of good ideas and lots of frustrations, I'm sure.
Hopefully June 3rd.
June 3rd. We'll see you there. Yes, sir.
Hi, Len and Rick and Branch. It was a great presentation. I just have one rather small question. Given the relative prices for the two plans and the out-of-pocket costs, it seems to me administratively you're going to have a land rush towards the basic plan, and it'll sort of cripple the growth of the establishment of the exchanges enrollment. I'm wondering if any of you could comment on that.
As Branch outlined, the basic health program, once the state adopts it, is the only source of subsidy for people under 200% of poverty. So they cannot go to the exchange to get the tax credit. It just becomes definitive. That's where that income goes. On the other hand, the people above 200% would go to the exchange. So because several of you have sort of raised this issue, I think, John appropriately pointed, I mean, this is partly an important moral and value issue around affordability and access for people that need affordable access. And so one question is, are there any alternatives? And I think there may be. They may not be as attractive to some interests and more attractive to others. But I'll just throw out one that we've toyed around with, and we'll be having a paper out shortly laying this out. One approach could be for the exchange to allow one, so it doesn't affect the tax credit, not two, health plans that have the most essential community providers in them in a given community to participate in the exchange. They would be, just as the numbers have shown, substantially less expensive than the average price plan. If that were true, the tax credit would still be based on a second lowest price plan. It might be a smidge lower because it would be a commercial plan that would have otherwise been the lowest price, but it would be about the same. What that would mean is this population could access that plan. Actually, if they're under 200%, if you ballpark it, they could access it for free with no premium contribution. And then in addition to that, the state, we could think under another provision, allow Medi-Cal plans to participate in general, all of them, in the exchange on a limited basis under a provision that says you don't have to guarantee issue to everybody if you're meeting your current enrollment. So you allow all the plans in Medi-Cal to continue to cover through an arrangement with the exchange their current Medi-Cal enrollees as their income goes up and they go to the exchange. If you did those two things, I think it would go a long way to solving the continuity problem for the people coming from Medi-Cal up to a higher income level, and would also give an affordable option for the lower income people in this range through the exchange, and would not create some of the other kinds of potential problems we talked about.
Thanks, Rick. Any other questions or comments? Just have to do the perfunctory, and please fill out your evaluations. This is where we get many of our ideas on how foundations can do the right work, as John suggested. And we try and be very focused in the kind of work we do. And I'll also say that while we were doing this project, we had lots of comments and ideas from many of you in the room, and Branch and I kept a very long list of, if we do a phase 2 set of analyses, we would answer this question and this question and this question and this question. So as this option and idea, and as the state grapples with goals to implement the Affordable Care Act, we're kind of ready to take this analysis further as needed, and so we're always here to listen and do good work. So I'd like to thank all of our panelists, particularly Branch and his team at Mercer, for a really great analysis, and all of you for coming, and stay tuned. Probably not the last you've heard of the Basic Health Program option. Thanks, everyone.